Good evening and welcome to our webinar on CBIT, Comprehensive Behavior Intervention for Tics. My name is Angela Sullivan, CDC Program Coordinator, and I will be your moderator for this evening. This webinar is being provided as part of the Tourette Health and Education Program, a program of the Tourette Association of America in partnership with the CDC. During tonight's webinar, we would be very happy to hear from you and include your voice in the conversation. You may ask questions or share comments using the question panel on the right side of your GoToWebinar player at any time. We will collect your questions and address them during the Q&A session at the end of the presentation. I would like to mention that funding for this webinar was made possible by our cooperative agreement with the U.S. Centers for Disease Control and Prevention. The views expressed by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. It is my pleasure to introduce you to our speaker this evening, Dr. Doug Woods. Dr. Douglas Woods is currently Dean of the Graduate School and Professor of Psychology at Marquette University. Dr. Woods has been working in the Tourette field for over 20 years. He has written over 250 articles and 9 books, including the CBIT Treatment Manual, and has received over $4 million in research funding for Tourette and related conditions. Through the TTAA's Behavior Therapy Institute program, Dr. Woods is a co-developer of the online self-help CBIT program, TicHelper.com, and he has trained hundreds of practitioners to do CBIT in North America, Europe, and Australia. Dr. Woods is a fellow of the American Psychological Association and the Association for Behavioral and Cognitive Therapies. He is a former co-chair of the Tourette Association of America's Medical Advisory Board and still remains active and an active member of the MAB. Without further ado, Dr. Woods, please go ahead with your presentation.
Can you hear me?
Yes.
Okay, good. All right, welcome everyone. We're going to talk today about comprehensive behavioral intervention for tics. Hopefully you can all see my slide set. I know Angela will be taking questions, so please write those down as you go, and we'll try to get to them towards the end. My goal for you today is to talk to you a little bit about comprehensive behavioral intervention for tics so you understand what we talk about when we talk about CBIT. This is a picture of Georges G. de la Tourette, who's the discoverer, if you will, of Tourette syndrome, and he showed you some of the key symptoms. He was a French neurologist in the late 1800s. Now, we know tics, which are motor movements and vocalizations, are involuntary. People can't control them, though they can be suppressed, which sets them apart from many other movement disorders. It makes them a little different than the other movement disorders. Tics can either be classified as simple tics or complex tics. Simple tics involve a discrete movement, a very clear onset, very clear offset. Complex tics look more either like chains of simple tics or more purposeful actions that are sometimes misidentified as purposeful actions like compulsions associated with OCD or intentional behavior. Tics can be simple motor tics or simple vocal tics. There can be complex motor tics or complex vocal tics. One of the key features of Tourette's that isn't in the diagnostic criteria, but is something that's really central to understanding why we would use a behavior therapy procedure to help people with Tourette syndrome manage their tics, is this concept of premonitory urges. Most people, right before they do a tic, can tell the tic is coming. It's this sensory experience that's been labeled premonitory urge. People who describe this well describe it as sort of a tension or a tickle or a pressure or an itch or an uncomfortable sensation that builds right in the area of the tic or more broadly throughout the body that is then relieved after the tic happens. And understanding that premonitory urge is going to be key to understanding, at least in part, why we would do behavior therapy for Tourette. So we'll talk more about that as we go along. Let's talk about where Tourette's stems from first, and then I think if we spend a little bit of time doing that, you'll understand why we do a behavioral model. My goal is to help you first understand why we would do behavior therapy for Tourette's, make sure you understand why that makes sense from a neurological perspective, and then we'll talk about what it is and then how well it works. So let's start with talking about how we typically do movement. Hopefully you can all see my cursor here, my pointer. And if you look at this part of the brain on the cortex, that's an area called the motor cortex. When we do a typical movement, there are neurons up in this area of the brain that store little bits and pieces of a movement. If I were to take an electrode and tickle this part of the brain with an electrode, maybe I'd get a flinch of a finger or a twitch of a neck muscle or something like that. Whenever we do a movement, these signals in this area of the brain activate and get sent down into another part of the brain, deeper in the brain, called the basal ganglia. It's this purple structure in here. The basal ganglia's job is to determine what bits of movement coming from up here are necessary for the person to do in a given situation. Many, many more signals come down from the top than actually get allowed through the basal ganglia and show up as movements. So the basal ganglia's job is really a filter. It takes out the unwanted movement signals, blocks them, and allows the movement signals that are necessary for a given situation to pass through the basal ganglia and then be executed as a movement or be done as a movement that we see. So the basal ganglia's job is to stop unwanted bits of movement. Now, how does the basal ganglia know what's a movement that it should let through and what's a movement it shouldn't let through? Well, whenever a movement happens, which means it has gone through the basal ganglia, it's been let through the basal ganglia, another part of the brain, which isn't on here, activates in reaction to what happens in the environment. So if a person does a movement and that movement results in something positive happening to the person, the basal ganglia sends a signal back to itself saying, hey, don't forget, the next time that signal comes through the basal ganglia, hits this purple part, something good paid off last time, so let it through again. All right, so a signal comes down, goes through the basal ganglia, something good happens to the person, and then a signal is sent back to the basal ganglia saying, hey, whatever you let through last time, let it through again next time because it paid off. There's a feedback loop there, in other words, that comes from the environment. If good things happen as a result of our behavior, that behavior tends to be repeated, okay? That's normal movement. Everybody does that. Everybody's brain works generally that way. Now, why do we think that area, the basal ganglia, is where most of the problem is in Tourette's? Well, we think that in large part because we know that some studies show the volume or the amount of basal ganglia, especially the caudate and putamen, is smaller in people with Tourette syndrome. Some studies have shown that there's a 10% reduction in volume in this area. And we also know that dopamine, which is a key neurotransmitter, seems to be a little overactive in these areas. And between those two findings, we think that the braking system or the filter system on movement may not be working as well. And that results in little bits of movement coming from up here. Little bits of movement slip through this filter when it should have been stopped. And we think that's what tics are, these little bits of movement that slip through the basal ganglia. Now, when these movements slip through the basal ganglia, if the environment reacts in a positive way, if something positive happens after this movement slips through, the feedback will be sent back to the basal ganglia saying, hey, don't forget, the next time that little bit of movement comes through, let it through again because it paid off last time. Something positive happened in the environment. And we'll talk more about some examples of what that could look like. The other interesting part about Tourette's is there's another pathway that can act as an emergency brake on all these signals coming down into the basal ganglia. There's a pathway from up here, part of your brain right above the eyes, called the prefrontal cortex, that sends wires or neural signals back down into the basal ganglia that can that can override what the basal ganglia does. It can stop you from doing things intentionally. So when we consciously have to control something, the basal ganglia can be controlled by activating this prefrontal area and intentionally trying to stop activity in the basal ganglia. That's what happens when we become aware of something that we're doing and intentionally try to pull ourselves back. So for example, if we're walking out into the street and someone says, hey, you're about to walk down the street, and we're not even paying attention, we look up and then pull ourselves back, that's this prefrontal cortex area stepping on the basal ganglia and saying stop, stop, stop. So that's how people with Tourette's can override those signals to control. You know, the movements themselves aren't voluntary, but we can exert some control over them because of this prefrontal area down into the basal ganglia. So that really forms the basis of behavior therapy. Now, let me talk about that in context. So the brain is the problem, that it's a neurological problem. The neurological problem leads to tics, but the tics happen in an environment. And if the tics lead to positive environmental reactions, you know, the tics occur and something happens that reinforces the tics, for example, we'll talk about examples of what that could be, that's going to change the brain a little bit. It's going to tell the brain, hey, the next time that situation shows up, tick again, do that tick again, because something good will happen. And so we need to understand from a behavioral standpoint how the environment and the tics interact so that we can control the environment. If we can control the environment, we have a decent chance of managing the tics more effectively. So let me talk a little bit about what the basis for behavior therapy is. The behavioral principles or behavioral treatment is based on three general principles. First, the person's environment can impact the symptoms. If you have Tourette's, which I'm assuming many of you on this call do, or at least have a child with Tourette's or a family member with Tourette's, I guarantee you can think of situations that will make your tics worse or your child's tics worse. You can think of situations that will make your child's tics better. You can think about people around whom the tics will be better or worse. You can think about internal states like boredom or anxiety or anticipation that will make the tics better or worse. In other words, we know that a person's internal and external environment, the feelings they have, the emotional states they have, and the external environment, the situations they're in, the people they're around, can impact the tic symptoms in a very predictable way. That's the first thing we understand and what we base our treatment on. The second thing is how the environment affects tics are unique to an individual. So what affects one person's tics in one way won't affect another person's tics in another way. Some of you may say, hey, when I watch TV, my tics completely go away. Others of you may say, when I watch TV, my tics explode. So that kind of thing can really be true. Everybody is a little bit different in how the environment predictably impacts their tics. And if we're going to develop a useful treatment, we have to understand how the external factors make tics change and how internal states, emotions, thoughts can make tics change. And we have to understand how it does that for the one person. And we need to deal with both of those factors for our treatment to be effective. So what are we talking about really when we talk about environment-tic relationships that we look for? We look at antecedents and consequences. Antecedents are those factors that come right before tics that make tics better or worse predictably. So different places or situations, being around particular people, certain activities that people are doing, internal experiences they might have. Then we also look at consequences. What happens right after tics that can make tics more or less likely to happen? So, for example, we might have positive reinforcement, and this is what we mean by this is reactions that people might have to tics. So, for example, let's say a child is ticking a lot, and he really likes to bang. He has a head banging tic, and he bangs his head a lot right when he's sitting next to a wall. That wall is a little bit tempting. So he starts bashing his head back into a wall over and over again. And if you're a parent watching this, you know, as he's sitting there beating his head into the wall with a tic and he's crying and really upset, as a parent, your first reaction as a good parent would be to run over there and comfort him and tell him it's going to be okay and rub his neck and all those kinds of things. All good parenting things to do. But if you think about what's happening in the brain at the time, what happens is this: that little head banging signal comes through the basal ganglia, and then the brain starts looking. Is there anything good that comes out of this head banging? Does anything pay off? Anything positive happen? And all of a sudden, the brain is flooded with a lot of positive stuff. It's positive, you know, being rubbed on the back, rubbed on the neck, told that you love your child, all that kind of stuff. The good stuff really starts to show up. And the basal ganglia says, hey, whatever you just let through there, whatever signal just passed through, the next time it shows up, do it again because there's a payoff, right? The basal ganglia is not thinking whether the child wanted to do it or didn't want to do it or is trying to do it or not trying to do it. It doesn't think like that. All it's doing is reacting to the environment. So there are positive reactions that sometimes happen to tics. There's also sometimes negative reinforcement or escape from aversive situations that happen because of a tic. So for example, if a child is struggling in class, maybe he has to do a reading assignment out loud and he's struggling in class and he starts ticking a lot and his teacher says, you know what, don't worry, I see you're struggling with your tics, don't worry about the reading assignment. Why don't you just put your book down and go out to the nurse's office and get your tics out and don't worry about it. No, that's not a bad piece of advice. We like to tell teachers those kinds of things, and the teacher's trying to be nice to the child. But in the brain of the child, what's happening? The child was very in a stressful situation, started to tic, and all of a sudden that stressful situation disappears. Well, in the brain, it's like something bad's happening, I tick, and then something good starts to happen. So the next time I'm feeling like I'm stressed, the tick starts because it's been reinforced in that situation. And so nobody's intentionally trying to do ticks. Nobody is causing ticks, but the environment reacts very carefully to, the ticks react very carefully to the environment. Okay, so if we understand that external factors, the environment that the person's in, can impact the ticks, then we have to come up with a way to deal with that. And that's part of what we do in CBIT. Part of what we do in CBIT is to try to identify the situations and the triggers for ticks and help the families and or the patients develop strategies to help them manage ticks more effectively. So the first thing we do is we identify those external, the world outside the skin, if you will, the external factors and some internal factors. We first identify what those factors are and how they impact the ticks. That's called a functional assessment or a functional analysis. We look for antecedents, the things that come before the ticks, and the consequences are the things that may be reinforcing the ticks. And we try to identify what those triggers are for that particular child. And after we identify them, we come up with a strategy that family can use to try to control those behaviors or control those situations more effectively. So for example, let's say a child ticks a lot in math class, and we find out he ticks a lot, he ticks in school, but his worst class is in math. He ticks most during math. And we find out that he gets really bored in math class. There's not much to do in terms of physical activity, and he's sitting in front and he feels like people are watching him, and that makes him anxious. And we know for this child that sitting for a long period of time and being made to feel anxious are both triggers for his ticks. Well, that would be told to us by the functional assessment. We'd learn that through the functional assessment. And if we do the functional intervention or the treatment piece of it, what we would do is make a recommendation to the family of, hey, you know what? Maybe instead of having the child sit in the front, let's have him sit in the back row so he can not feel like people are watching him so much. And maybe instead of having him sit through the entire class, every 10 minutes we let him quietly get up and stretch and move around a little bit in the back. And those two factors should help bring his ticks down a little bit to manage his ticks more effectively. Instead of sending him out of the room and not having to do his work every time his ticks get bad, maybe what we do is we have a safe place in the nurse's office when his ticks get bad that he can go do his work there instead of getting out of the work when he's doing a lot of ticks. All right. So we'll do things like that to help change the antecedents and the consequences to make the ticks less problematic or less caused by the environment, if you will. Now, there's another thing we have to think about, another issue we have to consider, and that's the negative reinforcement hypothesis. So remember, I talked a little bit earlier about this premonitory urge. The premonitory urge is the feeling that comes right before the tick, and it happens quite frequently. The premonitory urge shows up, builds, feels unpleasant, the child ticks. And I say child mostly because I work with kids. The child ticks, and the tick results in what? The relief from the urge. Remember, we talked about the basal ganglia looking for good things that happen after ticks. Well, one good thing that happens almost after every tick is this premonitory urge. This unpleasant feeling gets taken away as the child ticks, and that makes the tick actually stronger. So that cycle that's kind of built in, that urge leads to tick, tick leads to relief, actually serves to strengthen the tick. It makes the tick more and more strong. How do we get rid of that? How do we deal with that structure, that situation? Well, what we have to do is figure out a way to get the child to notice the premonitory urge, to get them to notice that the urge is present. In other words, notice when they're about to tick, and then do something that blocks the tick from happening, that prevents the tick from occurring. Because if the tick occurs, then you get relief. And if you get relief, you strengthen the tick. So that's what we're looking to try to do, is to teach the child to be noticing their urge, and before they even get the tick out, to be able to block that tick and wait long enough for that urge to fade away, because that's what ends up happening in most cases. In most cases, if you notice the urge and block the tick from happening and can wait long enough, it's not easy, don't get me wrong, then you'll get this thing we call habituation. And habituation is a fading of the urge. A lot of us habituate to things sensorily all the time. So when you put on your clothes this morning, if you put a new pair of underwear on, you felt it tight around your waist, right? And you noticed it for a while, but now you've been wearing the underwear all day, you don't notice it anymore. Your body has habituated to that feeling. that premonitory urge experience often habituates too. If you don't react to it, it'll fade away. Another good analogy would be like an itch. If you have an itch somewhere and you're in a meeting and you can't scratch that itch, a lot of times what you do is if you just wait long enough and get distracted and do other things, that itch will go away and you won't notice it anymore. And that's really what we're looking for this premonitory urge idea. The question is, how do we do that? We do that through a process, an older behavior therapy procedure called habit reversal training. Habit reversal training has three main parts: awareness training, competing response training, and social support. It was developed in 1973 by some psychologists, Nathan Azarin and Gregory Nunn. Azarin and Nunn developed numerous, or Azarin in particular, developed numerous treatments. If you've ever heard of timeout, that was an Azarin treatment. If you've ever heard of token economy or sticker charts, that was an Azarin treatment. And there were a number of other treatments that he developed. Habit reversal was one of them. The three main parts of habit reversal are awareness training, competing response training, and social support. In awareness training, what we're trying to do is to get the patient to be more aware of their tics. We want people to know every time they're doing the tic or about to do the tic. And some people get a little worked up about that. They think, oh man, you're just going to point out every tic I have and it's going to make me so self-conscious. The way we do it, we don't develop self-consciousness, so we develop self-awareness, and there's a different strategy that goes into creating each of those situations. But what we're really trying to do is get people to notice every time the tic happens or is about to happen, because then we can do something about it. We do that through three techniques: response description, response detection, and what we call early warning training. And what response description is when we work with the patient to come up with a very, very detailed description of what the tic looks like. I'm going to show you a little bit of a video. It's not going to be very long, but I just want you to see what response description would look like if a CBIT therapist were doing it. And in this case, the CBIT therapist is going to be me. So trust me when I tell you this, it should look something like this. So let me see if the video works. I don't know. Angela, you'll have to tell me if the sound actually works on this.
Okay.
Right, so Ty, you can tell.
Yes, I can hear it.
Okay. We decided that the first tic that you're going to deal with is the coughing tic, right? So when we always start to work on tics, we start. Tics.
Okay.
And what I need you to do is to come up with a really good description of your tic. Okay. So pretend I can't see, pretend I can't hear. How would you describe that coughing tic?
It's just kind of like a cough.
Okay.
Now, one of the things you'll notice is that I'm not going to pay any attention to his other tics. Habit reversal is done one tic at a time. We don't ever try to overwhelm the children. We identify the tics that the child wants to work on, that the child wants to manage. We make a list of them, and then we work from the most distressing tic they have to the least distressing tic. So we really start with the most bothersome tic first. We do habit reversal for that tic, work on it for a week or so, and then we add another tic that we start working on once that first tic starts to be controlled a little bit better. So we try not to overwhelm the child. So I'm only talking about this one tic he's doing. You'll notice I ignore the other one. So let's keep watching a little bit.
Just a cough.
Yeah.
All right. Can you do it for me a few times? Okay.
Kind of like clear my throat.
Let's see if we can come up with a little more detail. So let's start right at the beginning. Can you tell that it's coming?
Yeah.
How can you tell?
There's just kind of like a tension in my throat right here.
Okay. What does it feel like?
It's just kind of like itchy, I guess.
Itchy? All right. So how long before that itchy feeling happens and you start to make the sound?
Kind of like a second. It's pretty fast.
A second?
Yeah.
Okay, so there's a little bit of time in there
Mhm.
between when you get the feeling and when you start making the sound?
Yeah.
Yeah, that's good. So now I want you to think about that tic again. Maybe do it a couple times.
Okay.
And we're just talking about that one.
Mhm.
And I want you to think about what happens right after you get that feeling. What does your body do? What do you feel inside? How does your body move? What kind of muscle tension do you get when you do that cough?
Kind of like it's like almost like itching my throat kind of
Yeah.
right here.
And after that, what happens?
I cough it out.
Okay. So let's talk about how you make that cough.
Okay.
All right. So why don't you I want you to do it again, but before you do it, I want you to notice what you're feeling in your body.
Okay.
Okay, not the itching, but during the cough itself. So go ahead and do it. What do you notice your body's doing?
Kind of like moving forward a little bit.
Yeah, you kind of jump forward, right?
Mm-hmm.
Okay, so do it again. Okay. And again. Okay. What do your lips do?
Kind of like close in a little bit.
How so? Can you show me what it would do? You don't have to do the tick, but just show me.
Kind of like.
Right. You
Go
kind of
like
go.
O.
Yeah, like kind of an O.
Uh-huh.
And when you cough, what do your cheeks do?
They like suck in.
Try it.
They like, yeah.
They go in when you go like oh.
Yeah.
But what do they do when the cough happens? Did you notice that? Can you feel that?
Oh, they like expand kind
They
of.
go
Yeah. Yeah.
like that. Okay. What else happens in your face when you do that, when you cough?
It's like my eyes shut a little bit, kind of.
Yeah, you blink. You close your eyes tight.
Yeah.
Right? Okay, what else?
Kind of like my face just kind of like tension, I guess, kind of like stops.
So you'll see from that, what we're really trying to do is just talk in great detail and get him to slow down and think about this movement that he does hundreds of times a day. We want him to think about this stuff because he's never slowed down and thought about it. What is happening when he does think about it is we're activating that prefrontal cortex, that emergency brake part of the brain. We're getting him ready to do something intentionally to try to stop it, but he has to know it's happening first. So we really slow it down, talk about it in a very discovery-like way. It's not a judgmental way. It's a let's find out about this thing that's happened. Let's learn a lot about it. Now, after we do response description, which you just saw, we then do response detection. And in response detection, what we're trying to do is to have the child point out to us as a therapist in real time when the tic's happening. We're trying to get them to detect the tics for us and see if they're accurate. What happens is if the child correctly tells us the tic is happening, in other words, they raise a finger, for example, we say good job. If they miss it, if they tick but don't raise their finger, we say, hey, don't forget, you raise your finger whenever you have the tick, all right? I want to show you a little video of what that looks like. Oh, sorry, wrong one. Let's see if I can go back.
All right, Ty, you did a really nice job of describing your head jerking tick. All right. Now, what we're going to do is practice noticing it. If we're going to really learn how to control the tick, we need to know when it's happening. All right. So we're going to do a little exercise for the next few minutes. And what I want to do is every time you notice that tick happen, every time you jerk your head back, I want you to raise a finger just like this.
Okay.
If you catch it, if you jerk your head and raise your finger correctly, I'm going to say good job. If you miss it, in other words, if you jerk your head but forget to raise your finger, I'm going to stop. I'm going to say don't forget to raise your finger.
Okay.
Right? And the point of this is just to get you really good at noticing when you do that head jerking thing. Right?
Okay.
Now we're only going to work on the head jerking. So the complex tick and the cough I don't care about. It's just the head jerking tick at this point. Okay. So while we're doing this, I want you to talk to me about something that's interesting to you.
Okay.
Because one of the things I want you to do in real life when we get out of therapy is to have you practice noticing when you're doing your tick. All right. So that's going to be really important in learning how to control it. Okay. So you ready to get started?
Yeah.
Okay, remember, raise your finger when you tip your head back and you notice it.
Okay.
And if you miss it, I'll remind you. If you catch it, I'll say good job.
Okay.
All right. So what are your plans for the summer?
Let's see. I'm going to Camp Manitou
Okay.
soon. I think I'd go do that in a week, and I'm gonna be going there. Yeah, I think like a week. And I always do like really fun like pranks there and stuff.
Yeah.
And one time, me and so our cabin, we went to. Okay, so we went to the girls' like cabin, and we put all these like cups of water outside their cabin.
Yeah.
And so like then we went and banged on their cabin and we like scared them, and so then they all came running out of their cabin and they were like screaming, and then they ran out and then they like stepped on all the cups of water. And
Did you notice what you just did?
I raised my finger before I did the tick.
Yeah. So you kind of knew it was coming, right?
Yeah.
Okay, good.
Okay, so if the child, you can see how that works. We go back and forth. We make sure that they're good at detecting that tick. Sometimes it goes that fast. Sometimes it takes 2 or 3 sessions to get to the point where the child can be aware of their tick. But once they're aware of their tick, what we really want to get them to be aware of is when that urge is there. We call that early warning training. What you saw here with this child is he was able to get his finger up before he even ticked. So he was already aware of his urge. He knew it was coming and was able to raise his finger. When a child gets to that point, we're ready to go to the next step. The next step is competing response training. And competing response training, remember I showed you that graph of being aware of the urge and then blocking the tick from happening? That's what competing response training does. Competing response training teaches a behavior that the patient can do that's physically incompatible with the tick. They're supposed to do that competing response whenever they feel the urge to tick or even if a tick has happened. And they're supposed to do that competing response for a minute or until the urge goes away, whichever takes longer. There are 3 techniques: choosing the competing response, having the therapist show the patient how to use it, and then having the patient practice it. This is hard when I'm just doing this verbally to describe this, so I'm just going to show you how we would choose a competing response for a particular tick, and you can see what we would do. Oh, not this one though, I want to use this one. Let's see.
Ty, you did a great job coming up with the definition and description of your head jerking tick, okay? But what we're going to do now is to try to teach you an exercise that will help you stop that tick, all right? Because ultimately the goal is to try to get a little bit of control over that head jerking tick. So what I'd like to do is to come up with an exercise that you can do that will help you control the tick. And the exercise that you choose has to meet 3 rules, okay? The first rule is that any exercise that you choose has to prevent the tick from happening, or at least make the tick harder to do. All right. The second rule is that the exercise that you choose has to be less noticeable than the tick. Right? So it can't be as obvious as the tick. And the third rule is that you have to be able to do that exercise anywhere at any time for a minute or until that urge goes away.
Okay.
Okay. So again, the 3 rules: it prevents the tick from happening or makes that head jerking tick harder to do.
Okay.
It's not as noticeable as the head jerking tick, and the exercise you choose can be done anywhere, and it can be done for a minute or until the urge goes away.
Okay.
Whichever takes longer. So if you think about your head jerking tick, can you think of an exercise that might meet those 3 rules?
Maybe like holding my head like this.
Okay, so let's think about that. So if you hold your head like that, let's see if it meets the first rule. Can you hold your head like that and still do your head jerking tick?
A little bit.
Okay, so it might not meet that rule. What's more noticeable, the head jerking tick or you going like that?
Me going like this.
Maybe it depends, because a head jerking tick can be kind of noticeable. Can you do that anywhere?
That's kind of where it might be noticeable. Like in the mall, if I'm just walking around and going like this.
Yeah, that might look kind of strange. Or what if you're, pitching in a baseball game?
Yeah.
Yeah, that might be a problem, right? Okay. Or you're holding your bat, you're up the bat.
Yeah.
That might be a problem too if you jump up to do it. Okay. So that one has some problems maybe.
Yeah.
Okay? One of the things we commonly do when we have a kid with a neck jerking tick is we teach them to do this. We have them drop their chin a little bit and hold the sides of their neck tightly, not with their hands, but just to tense their neck slightly. Not too much, but just to tense their neck just a little bit, right? So not too tight. So once you do that, okay, let me check your neck, okay? Is it really tight? Okay, good. Just a little bit tight and hold your neck down, okay? And so once you do that, if you hold that position, can you throw your neck back or not?
Not really.
Okay. What do you think's more noticeable? Your head jerking or what you're doing right there?
My head jerking.
Right, I think so. Now, can you pretty much do that anywhere?
Yeah.
So can you hold that for a minute?
Yeah.
Okay. If it's too tight, if you're holding it too tight, then don't do that because we want you to be able to hold that for a whole minute.
Okay.
So that would be the exercise that we want you to do for your neck jerking tick.
Okay.
All right. Now here's how you do it. So remember, you're supposed to do that exercise 2 times. when you feel the urge to do the tick or when you've actually done the tick. All right. So if I'm sitting there watching TV and I feel that kind of urge in my neck, then I would go right into the exercise. I put my chin down a little bit, intense the sides of my neck, and I hold that for a minute or until that feeling went away. So at the end of the minute, I would ask myself, do I still have to do the tick? And if I do, then I would keep holding it.
Okay.
If I don't, then I would let my neck go. I wouldn't do the exercise anymore.
Okay.
All right. So that would be one example. But
so we will work with the patient to teach them that, and then we'll work with them and make sure they can know how to do it in session. And then we'll send them home. And what we send them home with are the instructions to use this competing response for that particular tick whenever they feel the urge to do that tick or whenever they actually have done one of the ticks. And the idea is they do this competing response behavior for a minute or until the urge goes away, whichever takes longer. Sometimes it takes a while the first few times you do it, and then it gets very quick after they practice it for a while. Now, the last part of habit reversal is a part called social support. And social support is where we ask usually a parent, if it's a child, but a person that the patient identifies as a support person. We ask that support person to do two things. We ask them to praise the child when they see, or the patient, when they see the patient use the competing response correctly. So if a parent's watching a child, the child suddenly goes into the competing response for a neck jerking tick, the parent should say, "Good job." Praise the child for doing so. If the other job of the social support person is to remind the patient to use the competing response correctly. So if the parent's sitting there watching the child and the child ticks but doesn't use the competing response exercise, the parent should say something like, "Hey, don't forget your exercise." Now, we caution parents not to do this too much. We tell them we're taking away their tick police badge, that they're not supposed to be on and watching their child all the time. This is really the child's treatment, and they have to implement it. The patient or the parents are really just helping as much as the child really wants. So CBIT, Comprehensive Behavioral Intervention, in summary, is habit reversal plus that functional treatment where we identify the antecedents and consequences and develop useful strategies for the family to use to manage tics. Now let's switch a little bit to the evidence for CBIT. How does CBIT stack up in terms of evidence? Well, remember, CBIT in large part was based on habit reversal. Habit reversal has been around since '73, and it was studied widely for 40 years using a lot of different kinds of research designs. And it's been around, and we've known that it could be effective for tics for quite a while. CBIT is the newer thing that resulted from an effort from the Tourette Association in 2002. They brought a group of us together and said, "Can you develop a non-drug treatment for kids with Tourette's?" So we came together, a group of us did, and we knew habit reversal would be a core piece of it, but we also knew that a comprehensive treatment for tics had to be a little bit more robust. So we added in the functional intervention that I talked about earlier. We added in a reward system to encourage kids to be in treatment and motivate them for all the work that they're doing in treatment. We added in a relaxation training piece because we know stress can make tics a little harder to control. And we added in a psychoeducation piece. Most importantly, what we did is compared CBIT to a control condition of psychoeducation and supportive therapy. And we studied these treatments, compared these treatments in two very large research trials. To date, I think these are still the largest treatment outcome studies that have been done in the treatment for Tourette's. Maybe there's one bigger at this point. The first paper we did compared CBIT. In this paper, it's called Behavior Therapy for Children, but it was CBIT to psychoeducation and supportive therapy in kids with Tourette syndrome. This was funded by the National Institutes of Health. The Tourette Association was actually one of the grant recipients. They helped coordinate this whole project. And this was published in the Journal of the American Medical Association in 2002. This study compared CBIT, and CBIT, by the way, was done in 8 sessions over 10 weeks, 6 weekly sessions, and then every other week for a couple weeks. The first 2 sessions were 90 minutes, the remaining sessions were 60 minutes. And what we found after 8 weeks of studying, after 10 weeks of treatment for these kids, is that 53% of the kids the tics had significantly reduced, and or they were performing much better socially. In other words, their impairment was reduced. That's 53% of the kids got much better relative to the supportive therapy kids, where 18% got better. And this was a statistically significant and clinically significant difference in favor of CBIT. We looked at a number of other measures too, and all of the measures were robust. The kids had fewer tics after CBIT. They had less tick-related impairment. The gains that they got maintained out to 6-month follow-up. So even 6 months later, the kids who had gotten better were still better 6 months later. Actually, we're in the process now of doing a 10-year follow-up to CBIT. The results aren't out yet, but we'll find out how kids who went through CBIT responded 10 years later relative to the kids who went through supportive therapy. We also did a study looking at the same treatment and how well it worked in adults with Tourette's. Essentially, again, we compared CBIT to a psychoeducation and supportive therapy for adults with Tourette's, and we found at the end of 10 weeks, CBIT was significantly better than supportive therapy. More people were better, symptoms were lower, impairment was lower for the adults who went through CBIT relative to supportive therapy. So looking at all those data, what we conclude was that CBIT's more effective than supportive therapy for reducing tic severity, for reducing tic-related impairment. And when we look at the kinds of results that we found relative to studies that had looked at medications, what it really looked like to us was that CBIT was about as effective as medications like Risperdal or Geodon or something like that. So with the atypical antipsychotic medications. The other thing that we looked at for CBIT was whether there were side effects of CBIT, and there didn't appear to be any. So what we really have in CBIT is a treatment that works about as well as antipsychotic medications that whose gains last and don't really have side effects. There's been one study published recently that compared CBIT to medication directly, and atypical antipsychotic medication, and what it showed is that both treatments, medication and behavior therapy, were equally effective. So there's some confirmation of our earlier beliefs. Now, that's the results of the CBIT outcomes. At this point, CBIT has been recommended by the European guidelines for the treatment of Tourette's, the Canadian guidelines for the treatment of Tourette's, the American Academy of Child and Adolescent Psychiatry treatment of Tourette guidelines, and I think upcoming the American Academy of Neurology guidelines as a first-line treatment option for people with Tourette. So what that means is if you have a person with Tourette's who hasn't had treatment yet, one of the things you should seriously consider as a first treatment is CBIT, which is different than it was 10 years ago, which is exciting for us. The question, though, is really, is CBIT being used? And we've done a few studies looking at that. We did a big survey on behavior therapy's availability, surveying parents of kids with Tourette's. In 2011, we published this. We surveyed 992 families of kids with Tourette's. And what we found, we asked them, what is the most common treatment, what kind of treatments have you gotten for your kid with Tourette's? And we found the most common treatment was medication, 83%. A lot of evidence for the efficacy of medication as a treatment for tics. Diet alterations, 30%. Not saying diets can't help tics, but the evidence isn't strong. It hasn't really been looked at in terms of scientific studies. Fatty acid omega-3 supplements, 24% said that was a common treatment for them. Again, there's really not evidence to support that. Again, could it work? Maybe, but the research hasn't really been done. Cognitive behavior therapy was fourth at 24%, and that doesn't even necessarily mean behavior therapy. But you can see behavior therapy, even though it might be one of the first recommended treatments, is not one of the most used treatments. So the question is, why aren't people using behavior therapy for Tourette's? And we asked that question. Is there a specific reason that your child hasn't had behavior therapy for Tourette's? And what we found is a few answers to that question showed up as more popular. One of the reasons was that parents said they were worried that asking their kids to suppress tics will cause other tics to start. About 18% said that's why they didn't go after behavior therapy. And what they're really talking about is worries about symptom substitution. In other words, yeah, I can get this one tic to stop, but if I try to stop this one tic, it's going to make other tics start. That's one belief. And another concern with that is what parents often see is it looks like at school their kids are holding their tics in all day, and when they come home, their tics explode. So they assume that holding in or suppressing all day causes tics to rebound. And that's not really actually been looked at empirically as a concern, but we have looked at it, and actually it's not what you think it is, and we'll talk a little bit about that. Another concern that people had, why they hadn't gotten behavior therapy, was that they said they didn't know where to go to get it. And another reason was that there was nobody close to them that provided behavior therapy. So what we've done over the last few years is to start to look at some of those factors for what are barriers to people using behavior therapy. Let's talk about a couple of things here. Is this idea of symptom substitution true? In other words, is it the case that if you stop one tic using behavior therapy, it's going to make others worse, or that new tics will start to replace the old ones that you've gotten rid of? Well, through the CBIT trial, when we studied this study, we actually asked the question of patients. Every week they came in, we asked if any new tics had started. We were looking to test symptom substitution. If symptom substitution were true, then the CBIT condition, where we were teaching kids to stop their tics or to manage their tics or to control their tics, if that was true, then CBIT should have more new tics start over 10 weeks than supportive therapy, where we didn't tell them or teach them how to stop their tics. And what we found at the end was not that. What we found at the end is it didn't matter what group you were in, whether you got CBIT or supportive therapy. At the end of 10 weeks, you had developed about 1 1/4 new tics on average. So that means what happens in Tourette's, as we all know, is tics just start. New tics happen. Sometimes they happen right after you gotten rid of an old one, and we think it's that the new tic started because you got rid of the old one. Sometimes they start at a different time. But we know from this study that CBIT does not cause new tics to start. What about this rebound effect? This idea that holding your tics in, it will cause a rebound in tics to occur. Well, first of all, let me say that in CBIT, what we do isn't really suppression, because suppression is when you're trying to stop all of your tics at one time. You're tightening up your whole body and tensing your whole body and focusing all your efforts on all your tics. We don't do that in CBIT. We deal with one tic at a time, and we do it in a very controlled way. So we're not quite doing suppression in the way that most people think about it. But what about when we do hold tics in? Is there evidence that the tics will rebound? We've studied this in a number of different studies. And what we find is in this study, for example, we brought kids into the clinic. We put them in a room and we watched them. We put the camera on them for 10 minutes. You can see where it says BL, baseline. What we found is when they were just free to tic, they were ticking about 8.5 times a minute. Then we asked them to suppress their tics for 5 minutes, and we helped them suppress their tics by giving them little rewards. Every 10 seconds they went without a tic, they got a little reward, and that was able to bring their tics down to about 2 tics a minute. So they were able to suppress their tics. The question is, what happened right after they suppressed their tics? If rebound is true, if rebound really happens, then right after they suppress, their tics shoot up way past baseline. But when we look at this statistically, this difference here wasn't statistically different. We then asked them to suppress 25 straight minutes. So 25 straight minutes of trying to stop their tics. And you can see they could. Their tics were much lower than they were at baseline when they suppressed for 25 straight minutes. 25 straight minutes of suppression, you would think, if rebound were true, would cause even greater rebound. But the truth is, it didn't even get back to baseline levels. And when we went for 40 straight minutes of suppression, and we asked them to stop suppressing to find out what would happen, what we found again is their tics didn't even go back up to baseline. There really wasn't evidence of suppression, of rebound, following suppression of tics. Now, we've looked at this in a number of other studies in a number of other ways. We've actually never found this rebound hypothesis to be true. What parents are seeing often is kids don't tic at school, i.e. they must be suppressing, and they come home and they tic a lot. That's very true. It's just, I don't think it's actually because of the suppression all day. It's because you're changing environments, and different environments can trigger different types of occurrences of tics. And I'm sorry I don't have a good 2 hours to go into that, but I could talk about that in much more detail if I had the time. What about these issues? Is there a specific reason that your child has not had behavior therapy for tics when you're don't know where to go to get this type of treatment, or there's no one close to you? What have we done to ameliorate those issues? Well, one of the things we've done is to write a couple books. We wrote this manual called Managing Tourette Syndrome, so therapists can read the book and learn how to do the treatment. That book describes for therapists exactly how the treatment should be implemented on a session-by-session basis. It's been translated into numerous different languages. The talks that we're doing today, we're doing these to raise awareness of CBIT and what it's about. The Tourette Association and the Centers for Disease Control project that brings things like this to practitioners and to families. And the Tourette Association also has created this thing called the Behavior Therapy Institute that is a 2-day workshop where therapists go somewhere and do a very intensive course where they learn how to do CBIT, and then they're hooked up with a CBIT trained therapist afterwards, where they go over consultation and get some support as they learn to do CBIT with a real patient. We've also looked at new delivery platforms, different ways of doing CBIT. We've looked at video conferencing, Skype type treatments, and online self-help. Our first study we did compared CBIT done face-to-face to CBIT done over video conferencing equipment. And what we found is tic severity reduced for face-to-face CBIT as much as it did for telehealth delivered CBIT. So you can do this remotely over teleconference equipment, and it works just as well as if you're sitting in the room with the therapist. We also looked at whether you can do it on something like Zoom or Skype in your own home. And what we found is that when you're doing it in this voice over internet protocol type delivery system like Skype or Zoom, you see a significant reduction in tics relative to a waitlist control. In other words, this treatment can also be done over things like Skype or Zoom. So you can do this remotely. We've also looked at developing an online self-help treatment. It's www.tichelper.com, and it's up and running now. It's a self-help version of CBIT based on CBIT principles, but there's no therapist involved at all. So that concludes what we've been trying to do and try to bring CBIT to people. Hopefully, an hour isn't usually enough to give this full justice in what it is and how it's implemented, but the purpose of today was to give you an understanding of why we might do CBIT, and also to give you a taste of what CBIT actually is and how well it works, and what we're trying to do to make it available to people. So I think we've got about 10 minutes left for questions. I'd be happy to take any questions that people might have at this time. And I think Angela is mediating these.
Thank you, Dr. Woods. We're now going to begin the answering questions that were submitted during tonight's presentation. As a reminder, you can still submit your questions through the question pane in your control panel. If we are unable to get to everyone's questions here at the Tourette Association, we have a full-time information referral staff who can answer your questions as well by emailing support@tourette.org or by calling 1-888-4-TOURETTE. So Dr. Woods, we got a few questions. We will start with one here. Could you please, what is the minimum age for a child to begin CBIT?
So the studies have looked at it down to age 9. The truth is, though, I don't know what the real bottom age limit is. If you've got a precocious 5 or 6 year old who can follow instructions and is a little bit insightful, you could probably get some good benefit. Now, even really young kids will do some version of CBIT. What we probably won't do with really young kids is the habit reversal piece. We'll do the education of the family. We'll do the identification of triggers in the environment and teach parents how to react to tics a little bit differently, so the chances of tics being reinforced by the environment are reduced. But we may not do habit reversal with the really young kids.
Great. Next question is, can you please explain the difference between CBIT and applied behavior analysis? The strategies sound just like strategies that this woman uses with children who have autism. She also has Tourette's, but am waiting to learn more about CBIT. Sure.
So applied behavior analysis is the branch of psychology in which CBIT developed from. So if you think about the broad category of psychology, a specialty within psychology is behavior analysis or applied behavior analysis. It came out of the Skinnerian tradition. Azrin was a student of Skinner. And so Azrin, when he developed this, he based much of this on what he knew from working in the Skinnerian labs. So his treatments, i.e. habit reversal, and ultimately which became CBIT, are behavior analytic treatments. They're a little bit different because they don't involve as much work from the therapist as a lot of behavior analytic treatments do, but it definitely came out of that same vein, which is why it sounds very familiar.
Great, thank you. So someone asked, how does CBIT work with someone who has ADHD and is impulsive and has trouble slowing down?
Yeah, so that would be a tougher one, a tougher case. That would probably take longer. we'd probably want to make sure the ADHD were treated before we tried to do CBIT, because CBIT you need to focus a little bit. You need to be able to follow instructions. And if the ADHD were bad enough that couldn't be done, we would want to make sure that the ADHD were well managed first before we started CBIT.
Great, okay. Okay, we have quite a few questions here. So the next question I will ask is, should you try CBIT if tics are currently in a waning period? My son has had complex vocal and motor tics, but currently tics are not bothering him.
Yeah, so two answers to that. First of all, if the tics aren't bothering the child and they're really causing no problems for the child, they're not hurting their self-esteem, not hurting them physically, socially, emotionally, whatever, and they're really just kind of there and nobody is too worked up about them, you know, I mean, the child themselves isn't too worked up about them and they aren't causing any distress, then I wouldn't do CBIT. CBIT should be used when tics need treated. And if tics don't really need treatment, in other words, they're not causing any impairment or interference, I wouldn't do it personally, because the child wouldn't be very invested. And the child has to be invested for this to work, because you can see watching these videos, the child has to do a lot of the work. And so if the child isn't motivated to do it, it wouldn't be very helpful. Now, we're all heading into summer, and for a lot of us, we know that the tics start to drop during the summer. A lot of times parents say, oh, well, that's when, you know, I should go in and get help because, you know, in the summer, that's when I have time to go. You know, my child has time to go to session. That's actually not a good time for us, because this treatment requires the tics to be there to do the work. You know, when you do behavioral treatment, what you're really doing is retraining the brain to do something different. But we need to have something to retrain too. And so the behavior that we're trying to work on really needs to be present for us to be able to do the most effective work. So if a child were in a waning period of tics, I would probably say, you know what, don't pay attention to the tics, just ignore them. But if they flare back up, then bring them back in and we'll do the work.
Great, thank you. All right, we're going to take a couple more questions here. Have you seen a reduction in tics with clients you've worked with? And if so, those who don't seem to respond to CBIT, do you have a hypothesis why 50% of it's effective and 50% it's not effective? Do they not practice enough at home?
Yeah, so there are a lot of answers to that. So first of all, one treatment, you know, there isn't a perfect treatment for everybody. No treatment works for everybody. And so sometimes you just have to keep trying to find the treatment that's going to work best for you. When I see treatments that fail, and I think it's the treatments that fail, not the person who fails the treatment, the treatments fail. Sometimes I think the treatment might be too difficult for some patients. They just can't comply enough. They can't do the work, or maybe the family situation is too tough at that point to be able to do the work, or maybe there's other issues that are getting in the way of them being able to do the work. I see a lot of times that's what the reason the treatments don't work. But generally, you know, even that 50% of those got clinically meaningful benefit. Another 25% actually saw their symptoms go down. It's just that more improvement could have been made. And so really, when you look at it, about 75% of the people will get something out of this. Another 25%, the treatment just doesn't work. And there are a lot of reasons that can be true.
Great. Does CBIT for coprolalia look different than for other tics?
Nope. We don't pay any attention to the content of what someone says. So they can say the F word, and that's just the same to us as doing like a coughing tic. We would use the same competing response, which in this case, for all vocal tics, we use a breathing competing response. It's a diaphragmatic breathing response. And for a tic like coprolalia, the competing response would be breathe in through the mouth and then out through the nose. Every time they felt the urge to do that tic, do a nice, moderately deep breath in through the mouth, out through the nose, and keep doing that pattern until the urge to tic goes away. You'll realize I want them to go out through their nose because they can't do the coprolalic swearing as they're breathing out through their nose. They have to stop breathing out through their nose to do the swearing. And so that's why we do it the way we do it. But the content of what they're saying doesn't mean anything to us.
Great. Okay. What if the child or teen doesn't have a premonitory urge or doesn't think he does, though he is aware that he is ticking?
Sure. Younger kids under the age of 10 often won't initially report an urge. That's about the time that kids start to report urges. But what we often find out is when we're doing that game where it said tic detection, where he was raising a finger every time he ticked, what we often find out is during that, the kids will start to raise their finger just like the kid did in this video, and they'll start to raise their finger before the tic actually happens. A lot of times they know the tic is there, the urge is there, they just don't have the language to describe it. But when we have them really focus on catching the tic, they'll start to notice that feeling is there before they even do the tic, and then the urge is fine.
All right, we're going to take one more question. Would you be able to speak to why CBIT training is less effective in adults, or is that true?
It is true. I mean, when you look at it, 53% response rate in kids and 38% in adults. I think there are probably a couple reasons for that. I think, well, probably the main reason is the kids have had this for less time. And, you know, as you know, the adults have had it for, you know, decades more, and the learning in the brain that has kept the person's tics going in the way that it has is more concrete. And so I think you're dealing with that too. Just a longer history of having that condition puts more pathways down in the brain that become harder to change. So I think that's one reason. Also keep in mind that, you know, many people will naturally grow out of their tics, and the people who are adults who still have tics may have a harder type of Tourette's to manage, right? Because they're the ones who didn't grow out of it. So there might be something different about that too.
Great. Thank you again so much, Dr. Woods. This is all the time that we have for our webinar this evening. Once the webinar is closed, you will receive a survey on the presentation, and we would appreciate if you would not mind completing that and providing your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of tonight's webinar. We didn't get to everyone's questions, so please follow up with us, whether it's Dr. Woods or the Tourette Association. Feel free to email webinars@tourette.org, and we can see if we can connect you with someone to answer your questions. Also, the webinar will be posted on the Tourette Association YouTube channel for those who are unable to participate today. We encourage you to reach out to us on social media about this webinar or for other ideas and suggestions you may have. On behalf of the Tourette Association, thank you again for joining us and taking the time to view our presentation. Have a great evening.